Raluca Drvu will show us how to assess patients with mitral stenosis. She will go through the specific findings that we have to look for at the level of the mitral valve. Then she will move to how to assess the severity using the various methods available. She will also address the limitations of this method. And finally, she will move to the complication at the level of the right ventricle, the right atrium, and the pulmonary pressure.
I have been asked to present a case of a patient who has a mitral stenosis, and I have chosen the classical example of a patient who has a rheumatic mitral valve stenosis. You will start your examination from the parasternal long axis view. You put your probe and you try to find the parasternal long axis view. And you can clearly see from the start the restrictive motion of the anterior mitral leaflet with reduced mitral valve opening during diastole. This is one of the best images in which you can assess the mitral valve morphology assessment. You can see here the landmarks of the rheumatic mitral valve stenosis, which are actually the dooming of the anterior mitral leaflet in diastole, and also the apical thickening of the apical portion of the mitral leaflet tips, together with the fusioning of the chordae, which actually create a restriction of the posterior mitral leaflet. You see here that the fused chordae are actually leading to a restrictive systolic and diastolic motion of the posterior mitral leaflet. Further on, if you can just tilt the probe toward the medial aspect of the left ventricle, you can already see the fused commissure over here. So you have the anterior mitral leaflet dooming in diastole, the restriction of the posterior leaflet, the fused chordae, the thickening of the leaflet tips, and also the fused commissure that you have seen here just by tilting the probe towards the medial commissure. As you know, rheumatic valve disease does not stop at the level of the mitral valve. So you have to check in the parasternal long axis view also the LVOT and the morphology of the aortic valve. And again, as you can see, there are just a thickening of the leaflet tips, which is a hallmark and the first modification in patients who have rheumatic valve disease. By applying the color Doppler, you can already check for stenosis, which was not the case because you were seeing that the leaflet was opening clearly on 2D grayscale. And also you can check for the presence of the aortic regurgitation. And you see here that this patient has a mild aortic regurgitation, probably related to the fact that the leaflet tips are just thickened and retracted and the coaptation is not well enough. Then you can apply the color Doppler to see exactly the restriction of the leaflets in systole and the fact that the flow from the left atrium to the left ventricle is actually impaired in diastole in the patients with mitral stenosis. Again, something which is very important is just to turn the probe 90 degrees and go into the parasternal short axis view. And here it's an intermediate view at the level of somewhere between the papillary muscles and the leaflet tips, because you will start scanning further to find the morphology of the mitral valve also in the parasternal short axis view. And by going upper, you see here that I'm just moving the probe at the level of from the papillary muscle to the level of the mitral valve opening, and I'm seeing here beautifully the mitral valve orifice in diastole, who has a fish mouth appearance. You see the thickening of the anterior mitral leaflet and also of the posterior mitral leaflet, the fused commissure, and this opening in diastole, which has the name of fish mouth opening, which is characteristic for patients with rheumatic mitral valve stenosis. Also, when you're trying to assess morphology of the mitral valve in patients with rheumatic valve disease, it's very important to assess and to search for the degree of valve calcification. Here, this patient does not have any important calcification of the mitral leaflets because we would have seen reverberation and shadowing, but it has however, a mobile anterior leaflet, the fused commissure, and very thick leaflets. If you further zoom on the valve, you can see again the same aspect. The fused commissure are really nicely seen and the opening of the mitral valve. Assessment of mitral valve morphology is very important for clinical decision making. And you know very well there are two scores that are being used, the Cormier score and the Wilkins score, who are based entirely on mitral valve morphology. By assessing this score, especially with transesophageal echocardiography, you can reliably send the patients to PMC or defer such an intervention on such patients. Now let's move on to the quantification of mitral stenosis by transthoracic echocardiography. And we will mainly concentrate on assessing the mitral valve area by planimetry, which is actually the gold standard of assessing mitral valve stenosis severity. It's 2D planimetry valve area. This is done in the parasternal short axis view. Again, you start at the papillary muscle levels and then you go up to the mitral valve orifice by carefully scanning and angulating the probe and tilting the probe to find actually the smallest orifice. Usually when you see the commissural fusion, there you have the smallest orifice. And then you can do a zoom in. It's important to do a zoom in for the accurate quantification of mitral valve area planimetry. And then what you can do is just to lower the gain, because too much gain, as you see in this case, if I increase the gain, too much gain actually will lead to an overestimation of the severity. So you lower the gain, you freeze the image, you go in mid-diastole, and you trace the mitral valve area. You'll start from the commissure and we'll go to the black and white interface, going clearly around the leaflet borders up to the first commissure, and you see here that I have a mitral valve area measured in 2D planimetry of 1.3 centimeters square, which suggests a significant mitral valve stenosis. Just as a reminder, a hemodynamically significant mitral valve stenosis is defined as a mitral valve area of less than 1.5 centimeters square, while a severe mitral stenosis is defined as a mitral valve area less than 1 centimeter square. So now you have done the planimetry of this valve area and you see that this patient has probably severe mitral stenosis of rheumatic etiology. Another way to quantify the mitral valve area is just by measuring the pressure gradient, because you know that where the mitral stenosis is present, there is flow acceleration across the mitral valve in diastole. We have high velocities and thus high diastolic gradients. So by looking at the gradients, actually you can assess how the severity of the mitral stenosis. The higher the gradients, the more severe the mitral stenosis is. So we go in the apical 4-chamber view or 2-chamber view or 3-chamber view, it doesn't matter. But what is important is to detect by color Doppler the direction of the flow into the left ventricle, because it's crucial for measurement of the gradient. You have to really align with this flow, have the smallest angle between your line and the flow direction to have the highest gradient available. So this is why I'm going to do in this patient. I'm just going to put the color continuous Doppler on, align with this, tilt a little bit the probe to get the proper alignation, and just turn on my continuous Doppler. And here is the tracing that I've got, in which you see the velocities, all velocities across diastole, which will enable me the calculation of the mean and the peak gradient. As you know, the peak gradient is related to the peak velocity through the Bernoulli equation, while the mean gradient is assessed by averaging the instantaneous pressure gradient during diastole, from the beginning of diastole to end diastole. So you were well aligned with the flow and you put your continuous Doppler on and you have such a flow. And actually by doing the tracing, you'll be measuring the mean and the peak gradient. And this patient, you see that has a peak gradient of 14 millimeters of mercury with a mean gradient of 8.8 millimeters of mercury, which actually corresponds to a significant mitral stenosis, and according to the ESC guidelines, to a patient who has a moderate mitral stenosis. However, you have to I have to remind you the fact that, as I said before, the most important is to do 2D planimetry of the mitral valve, is the recommended measurements. It does not depend on the flow rate, it does not depend on the the presence of the concomitant mitral regurgitation, and it correlates very well with the mitral valve area that was found in explanted heart. So it's actually the best, the gold standard in echocardiography to assess mitral valve severity. As a second line, you will have the measuring of the peak and the mean gradient, but you have to know that they are also very dependent of the heart rate, and also very dependent on the flow. So in patients which have atrial tachycardia or rapid heart rates, the gradient will actually be higher. It will overestimate the mitral valve stenosis severity. So you have to, in this case, you have to just note in your protocol the heart rate at which the exam was made, and also remember to take the patient again for a second scanning when the heart rate is lower than 80 beats per minute. Also, think of being very suspicious in patients which have anemia or other kind of high output states like hyperthyroidia or sepsis, because in this case the increase in the flow over the mitral valve would lead to an very increased mean and peak gradient and to an overestimation of the mitral stenosis severity. The third modality that you can use to assess the mitral stenosis severity is what we called the pressure half-time. Again, the pressure half-time has to be measured in the apical, one of the apical views, which one you feel best. And the secret is just to see which is the leaflet tip opening with the smallest orifice, and then to put your pulse Doppler at this level, exactly at the level of the smallest opening of the mitral valve. And you'll have a tracing like this one, in which you see a very nice slope. So the pressure half-time has to be measured on the first slope of the diastolic tracing, which corresponds to the E wave. And actually, if you have a patient who has two slopes, the slowest one has to be taken into consideration. I will just do the measurement here. I will try to stay parallel with the slope. I will choose the slowest slope, and you see here that by pressure half-time method, I have a mitral valve area of 0.9 centimeters square. This equation was validated. Actually, this is based on the equation validated by Leaf-Hattel, in which it's a constant 220 divided by the pressure half-time, which gives you the mitral valve area. You don't have to forget the fact that this stands only for mitral valve stenosis and also for native valve, so not on prosthesis to derive the mitral valve area, and neither on pulmonary or another valve. So another way to quantify the severity of the mitral stenosis is by applying the continuity equation, which actually tells us that what goes to the mitral valves have to come out through the LVOT, or what goes into the pulmonary artery has to come out through the mitral valve. And this is a technique which actually can be done in clinical practice only when you have discordant measurements between the mitral valve area by planimetry, the mean gradient, and also the mitral valve area derived by the pressure half-time. It's a more tedious and more laborious method, and it's rarely used in clinical practice, but when you have discordances, you can always use it. This can be applied, as I said, at the level of the LVOT or at the level of the right ventricular outflow tract, because it stands on different measurements that you have to be done. It's more prone to error measurements, and this is why we don't do it usually. The last method to assess the mitral valve stenosis is the PISA method, which actually it's based on the continuity equation and also of the proximal isovelocity concept. To do this, you will need an apical four-chamber view, which is zoomed, in which you apply the color Doppler one like I did here, and you see you have to switch the baseline toward the direction of the flow to have a good delineation of the proximal isovelocity surface. And then what you have to do is just to stop your frame in the mid-diastole, in the frame in which you clearly see the neck of the vena contracta and the very nice PISA radius that I have measured here as 1.2 centimeters, corresponding for a lyzing velocity of 39. And by also knowing the velocity time integral of the continuous Doppler flow, you actually can derive the functional mitral valve area. So another way to be more sure of the assessment of the mitral valve stenosis is to do the 2D planimetry, of the mitral valve with the help of 3D imaging. And the best and the most easy technique is using the biplane method, in which you see I'm starting the acquisition in the parasternal long axis view. I have an image like this, and I can freely move the sagittal plane from the left ventricular apex to the base of the mitral leaflet at the level of the smallest visible orifice, to have actually in this image the smallest orifice available. You can just zoom the image, and then you can just do your freeze and do your tracing. And as I done in these patients, that has a mitral valve area of 1.3 centimeters square, which is totally concordant with what we were measuring earlier. This is a more easy to do technique, because assessing of the 2D planimetry, however, takes a lot of skills, because you have to be sure that you're at the level of the smallest orifice, so you have to turn the probe in all directions to have really the smallest orifice. What you can also do is just to acquire a 3D zoom volume of the mitral valve, like I did in this case. And you see here I've acquired, it's not a 3D zoom, it's a full volume 1-bit acquisition done from the apical view, in which you can see here that I'm looking at the mitral valve stenosis from the left atrial aspect. Here is the left atrial appendage. This is the anterior mitral leaflet. This is the posterior mitral leaflet, and this is the orifice opening in diastole. You can freeze on the volume like this. You can use multi-slice, and what you can do is just to orient your planes and cut in different directions to have really the smallest orifice available. This one is represented over here. So I will show you now the result of the planimetry done by 3D valve by cutting and cropping this volume. And you see here that the gain was lowered to avoid overestimation of severity, and the mitral valve area was traced exactly at the minimum opening, and we have a mitral valve area of 1 centimeter square, which is actually a severe mitral stenosis. And at the last, what you have to assess is the consequences of the mitral stenosis over the left atrium and also over the right cavities, the right atrium and the right ventricle. And to do this, you will need an apical 4-chamber view, in which you will be given the volume of the left atrium, as I will do here. You can use the Simpson method of this, which is strongly advised, or you can use the area length method to measure the volume. You can start tracing the endocardial border. You have to avoid the pulmonary veins. And you'll have a volume of 135 milliliters. And you can do this also in the 2-chamber view by freezing the image, going to end systole, measuring, giving the volume, and you see that this patient has a very dilated left atrium of 179 milliliters. If you would index this for body surface area, which is important, you know that the presence of left atrial volume above 60 milliliters per meter square is already an indication for oral anticoagulation. So assessing the left atrial volume is really important for clinical decision making in your patients. And lastly, what you can do is just take a look at the right ventricle, because the presence of a mitral stenosis significant mitral stenosis has repercussions on the left atrium size and on the pulmonary artery pressure, and also on the right atrium and the right ventricle, which becomes, they are facing overloading pressure, and thus they become dilated, and also regarding the right ventricle hypertrophic, and at the end stages they can become dysfunctional. And you can see here from this patient that there is a not so important dilation of the right ventricle, because the basal diameter is 3.7 centimeters, but what you can see if I take my measurement off, is actually that this patient seems to have some kind of hypertrophy of the right ventricle. So this suggests, it's an indirect finding that suggests that this patient has probably pulmonary hypertension. So estimation of pulmonary artery pressure is also important in your patient with mitral stenosis, and you can do this using continuous Doppler by looking at the velocity of the tricuspid jet. I've put here the color Doppler on to detect the direction of the jet, and then the idea is to put the continuous Doppler well aligned with the regurgitation, tricuspid regurgitation jet to get the maximal velocity, systolic velocity across the tricuspid valve, and thus the maximal gradient, systolic pressure gradient, which is of almost 30 millimeters of mercury. Lastly, you have to look of the inferior vena cava diameter and to add the right atrial pressure, which can be either 5 if the inferior vena cava is normal compliant, or 10 to 5 if the inferior vena cava is dilated but still compliant, or more than 20 millimeters of mercury if the inferior vena cava is dilated and non-compliant. As I said, it's also important to assess right ventricular function, and here I've used M mode across the tricuspid annulus, in which I can measure the maximal tricuspid systolic excursion, which in this case I've used the tissue Doppler to facilitate a little bit the distinction between end diastole and systole. And you see that this patient has a normal right ventricular function of with a TAPSE of 1.8 centimeter, which is superior to 1.6, which actually tells us that this patient has normal right ventricular function. So I hope I've convinced you that transthoracic echocardiography is really a key exam in the evaluation of patients with mitral stenosis, because it gives you information regarding the positive diagnosis, the differential diagnosis, the assessment of the mitral valve or morphology, assessment of mitral valve stenosis severity, and also assessment of the consequences of mitral valve stenosis on the left atrium, pulmonary vascular bed, and also on the right ventricle.
So the lessons to be taken from this examination is that we have, of course, to use multiple views, multiple modalities to estimate the mitral stenosis. But also a very important key point is that we have to take into account the heart rate, because this can lead to an overestimation of the mitral stenosis severity, and therefore this should be part of the report.